Thank you so much. Got it. Thank you so much for inviting me. I really appreciate it. This is something I've been sharing with my teams for a couple of years and developing for myself for my whole career. I'm hoping it's something that's of value to you. Before we start, I just want to take a brief moment for us to all sort of set our intention together. We're going to transition from the super high cerebral space that we all spend a lot of time in into a little bit more of a mental health, spiritual, empathic space. And that can be jarring. There is a little bit of neuroimaging and some science fun, so don't worry too much. But let's just take a few moments, however you do, to take a few deep breaths. If you have a mindfulness practice, a prayer practice, or just find that tranquility. And today we're going to really explore some ways to take care of ourselves a little bit more skillfully and to take care of our patients a little bit more skillfully. So we're just going to take 3 breaths together. And I'll just pause, a moment of silence for that. Okay, thank you. We're going to talk about the cost of caring. My goals and objectives today. I'm hoping to deepen our understanding of trauma as it affects caregivers. I'm hoping to bolster our options for providing trauma-informed care to our acute care patients. I'm a hospitalist, so I'm going to kind of live in that space, but it flows very easily into the other spaces where we care for patients. I'm going to spend a lot of time discussing definitions. Definitions of trauma, vicarious trauma, compassion fatigue, and burnout. The literature is a hot mess in terms of definitions. And the idea here is to discuss the ideas behind them and then be aware that if you're ever talking to other people that they may have a completely different word for it. And so just be cautious and make sure you explore the ideas so that this kind of messy field of language doesn't get too problematic. We're going to familiarize ourselves with the idea of low impact debriefing. I think this is an essential skill going forward and something that I've learned I'm not late career, but pretty late given the amount of training and practice that I've had already. I think it's a very useful thing. Finally, we're going to list and kind of explore some of the teams and referrals available for our patients who are experiencing more acute or recent traumatic events. I do want to make a couple of clarifications. One, when I say trauma, I'm talking about the sort of the PTSD, the abuse, the lived experiences, not broken bones, which is something that's very problematic as you go through this literature in PubMed, is that you come up with some Boolean term and it's like, oh, here, like tibial fractures. And you're like, no. And so that I wish that we could have a different word. I personally like suffering, but that won't help you with your mesh tables in PubMed. So trauma it is for now. I also want to mention that I do come from a Buddhist perspective. And so whenever that's oozing out, it's not something that I'm trying to force on, but it just fits quite nicely into this field. And the field has borrowed very heavily from Buddhist traditions of thought. And so that it's just kind of in there. So just sharing that as my sort of place I'm coming from. So we're going to start by focusing on caring for ourselves, and then we'll move to caring for others. Secure your own mask before helping the one next to you on the plane. You guys remember planes, right? Okay, so at the highest level, we have SAMHSA. This is the kind of federal care oversight. They talk about individual trauma resulting from an event, a series of events or a set of circumstances that's experienced by an individual as physically or emotionally harmful or life-threatening, has lasting adverse effects on the individual's functioning in the mental, physical, social, emotional, and spiritual well-being. So a broken tibia can fit into that although I would argue, like I had a friend playing in the yard, broke his tibia, got better, and it has not today had lasting effects compared to unkind words from a parent as a pattern or something like that. Certainly a sexual assault um, certainly meet this criteria better. So this is where we're coming from. Let's bump over to MD Calc here for a moment. So this is the DSM-5 post-traumatic stress disorder little helping you through thing. I want to point out that when we're talking about ourselves, we may fit into this criteria. Directly experiencing the event, witnessing it as it occurred to others, learning that, about an event, or experiencing repeated or extreme exposure to aversive details of a traumatic event. So this last one is the one that we all check. We see this every time we come to work, probably. The lives that we are touching are just filled with direct trauma. Now, this doesn't actually give you very many points as you go through this. As you know, as we go through, it's really, are you re-experiencing things? Are they inhibiting your ability to function? Many of us check this box and then utterly fail to meet the diagnostic criteria for PTSD. So we need a new definition because there is something happening to us that is deleterious and needs to be addressed, but it's not this disorder necessarily. And our patients, right? There are people who do not meet PTSD. It's not on their problem list, but it may be underlying everything about the patient. So, ooh, this is weird. Okay, thank you, PowerPoint. Definitions. So I'm going to take us all the way back to the bad old days of the 1940s when we had like aspirin beta blockers and white men. And the beginning of this field really started in an almost, it was post-Oslerian, but pre-anything good happening. And really there was this idea, and the language frequently in this old literature refers to detached concern, helping med students facilitate and build this detached concern. If you were too attached, it was problematic. And if you were too detached or not concerned, you weren't a caring physician. They wanted to have a good bedside manner. It wasn't totally inhuman, but it had a ways to go. I do want to give this some props. I think detached concern is a form of mild dehumanization, or at least from where we are today in our sort of modern ways of trying to care on average. This is mild dehumanization. It's on the spectrum of what we do in order to be able to engage in war, of seeing someone as other than human. It's at a very mild end of that spectrum, but it does a huge thing for us, which is lets us have full access to our executive function. If you fully embrace the humanity of the person in front of you every moment, good luck with your rapid response, right? You can't be in a sympathetic, oh my God, this poor person is suffering that I fully identify with in every moment. Sometimes you just have to think about, the rhythm strip in front of you and the gas. Sympathy and empathy are one of the biggest messes as you go for definitions, and people like to flip it. The Europeans and Germans have literally opposite definitions. So I'm just going with this. Sympathy is understanding how someone might feel. It involves kind of understanding from your perspective. So I see how you're suffering. If you've ever worked with someone kind of dealing with high functioning spectrum of autism, this is the training for people who have less than ideally functioning mirror neurons. Look at their eyes, look at the shape of their eyes, look at their nostrils. That means on your little chart, they're feeling this feeling, right? So it's a little more on that detached side of the spectrum. Empathy is really engaging those mirror neurons of feeling their feelings in yourself. It's putting you into their shoes. Empathy, I think we may have a reflexive sense here that as I'm going down this, I'm improving, I'm getting deeper into the patient, I'm getting more 20/20 about this. But I would say that empathy comes with harm. If you're really truly empathic and feeling your patient suffering for yourself, that can come with a great price tag, and that's kind of the focus of what we're talking about. Taking this a little further, compassion is a really complex thing, but I think that compassion, everyone has a different definition. This comes from the longtime translator of the Dalai Lama, who's now a PhD, who's playing in the sort of neuroscience of empathy and compassion. So these are the kind of points that he would give for this. Awareness of the suffering, sympathetic concern related to being emotionally moved by the suffering. So you are aware of it, you feel it, and then that gives you a drive to do something about it. You have a wish to see the relief of that suffering, and you have a responsiveness and readiness to help relieve that suffering. This is a good day at work. You go down to admit you see the suffering, and you're in a position to help them. You want to, and you're ready to help them in your heart. I know you've all been there, and I know you've all been when you've gone and seen someone, and you're just kind of going through the motions to some degree. So compassion, I think, is really helpful. I want to mention equanimity. The dictionary definition is stability and composure in the setting of difficult times. So as you build from sort of, oh my gosh, MS3 to the sort of skillful, I've seen it all, R3, picture yourself in, through that transition in an RRT. Oh my gosh, what's going on? I can't deal with this. And then you build stability and composure. Yes, they're bleeding. Yes, we're doing a code even, but I know what to do, and I'm going to stay kind of in the groove. That's the dictionary definition. I'm going to borrow from Buddhism here for a moment, because I think this can be a really helpful framework, and everything dances around these definitions, if not outright uses them. These are the Brahma Viharas, which are basically kind of lovely ways of being that we should try to cultivate in ourselves. It would be a nice way to say it. So there's loving kindness, Maitreya, which is really seeing someone and being with someone in a loving and pleasant way, having a benevolent wish for them. Compassion, as we kind of touched on, really is seeing their suffering, wanting to do something about it, being open to being moved to do something about it. Empathic joy is the flip side of that. So if you imagine a kid getting a toy that they're super stoked about, and you love that kid and they're really happy about it, you're feeling empathic joy. Do you feel empathic joy for the dude who just bought a big monster truck and then buzzed past you with it? Maybe that's a challenge, and we could cultivate that. So finally here, equanimity, really, we often, I think, could contrast this to the sort of dictionary definition. This is just having that little bit more distance. So instead of just being composed in an RRT, this is a little bit more like the grandparent who's not in the hectic, oh my gosh, I'm taking care of every single thing. You're just a bit more removed, which comes a little full circle to that 1940s idea of detachment, but you're not letting everything kind of hit you. You're not responsive to everything. This is just sort of the empathy versus sympathy idea of, are you housed in yourself, or are you kind of bringing them into your perspective? From a neuroimaging standpoint, we've done brilliant work with functional MRI, looking at kind of where the self-other distinction comes from, how we share affect, and all of this is actually pretty different from building compassion. This is one of my favorite studies, looking at empathy versus compassion. So they trained, one group got empathy training, then compassion, one got compassion, then empathy, and basically showed, I'm not going to go into the details, but then they showed people in an fMRI people's suffering, people's like getting their hands stabbed and going out with their face. And the negative pain-related sort of responses were heightened in people who got empathy training. So they felt those feelings more and had a more negative experience. The people who got compassion training had less negative experience. They had a lot of other things going on, but less of that, which really kind of gets to where we're headed now. You've probably had several talks by now about burnout. I'm not sure where you are, but if you've made it to PGY1, you've had a few burnout talks. I think it's really important to make some distinctions here, because I think burnout is important, but by no means all of the problem. Burnout is the physical and emotional exhaustion experienced in the context of a low job satisfaction and or overwhelming demands. Does this sound familiar? We use it all the time to explain the suffering of trainees. But there's more. Moral distress. occurs when we're forced to do things that we fundamentally disagree with or that we are morally opposed to. And I think this isn't necessarily something that you're like, this is absolutely wrong, but continuing someone's care that you're seeing suffering who's not ready to kind of go into a comfort care is a great example that you're not like, this is absolutely morally wrong, but it will cause moral distress. This is a term that really comes from the medical ethics field. Primary trauma caused by the traumatic event that happens to you. It can be from your personal life or caused by a work-related exposure. So let's not forget that we have real lives, and some of these have had traumatic things in them. And where did my secondary trauma go? There it is. Secondary trauma is basically the exposure through the H&P, right? It's that you're hearing the story, you're sitting there at bedside hearing some really difficult things. Now these lead to some injury. Moral injury is kind of one of those things, but longer term, these are things that get misdiagnosed as burnout for years. And I think through my training, this language was not present. Compassion fatigue. It's a profound emotional and physical erosion occurring when providers are unable to be refueled and regenerate. Vicarious trauma. Transformation of our worldview due to the cumulative exposure to traumatic injury images and stories. This is a profound restructuring of our brains, our minds, our souls, if you're into that, to this like hard, difficult, full of suffering world that we live in any of our care systems that we're part of. These are different things. They're really related, and they're very different from burnout. So first of all, a person working at Wall Street can get burnout. The job is just too hard. They can't do it. They're not loving it. It's just too difficult of a job. Now, these other two problems are things that really come from caring disciplines. And so you are not getting compassion fatigue and vicarious trauma at Wall Street. I mean, maybe there's a way to build a story there. I don't know. There's this language from Vandernoot Lipsky, who wrote the book Trauma Stewardship, and she's been engaged in giving some talks, which I highly recommend. She's an amazingly dynamic person and just really awesome to hear her speak. So any chance you get, I recommend it. Trauma exposure response, a transformation that takes place within us as a result of exposure to the suffering of other living beings on the planet. I think it's important to broaden this. The book has great examples of like a frog ecologist who's just like, their world is morphed because they're watching frogs as the sentinel of environmental changes, and they're just like grieving for the planet, and they're just experiencing a lot of harm, but it's not a human story necessarily. So you can have one or both of these things. Vicarious trauma is this transformation of our worldview. So I want you to picture a part-time forensic psychologist with a cush job. Forensic psychologists kind of hear the story. They often spend very little time with the patient, and their goal is not to cure, diagnose, or really help the patient. They are kind of functioning in a criminal court capacity, and so it's a very different job from the rest of us doctors who in one way or another are trying to help people. So they are still hearing some really intense stuff and are being constantly bombarded by horribly traumatic things. But I made their job easy to clarify that it's not like they're unable to do their job, and their job is not healing and curing. So they may have VT without CF. CF is the profound emotional and physical erosion when you're unable to be refueled and regenerate. And burnout really is tied in here with the I'm unable to do my job well. So the overworked sniff worker at Klein-Gallon or some affluent sniff where you're not hearing particularly crazy stories and the sniff's working really well and doing a good job, but you are exhausted and you aren't able to refuel and regenerate. So you kind of run out of the ability to provide compassion. So I think it's really important to tease these apart, because whatever's going on for you and as alive for you at a moment may be one or both of these, and you need to kind of have a sense of where they're coming from. I would invite you, I'm going to move this for time to a little bit later, but I think it's really important to ask ourselves a few questions along these lines. One is, where do the stories go? At the end of the day, we've seen all this stuff. Where do those stories go before we go home? Or how did they come home with us? Were we trained for this? I'm curious if this is the first time you're experiencing some of this language. You're welcome to text me directly in chat. If there's other places that you're getting this from, I'd like to hear about it, because I've asked a lot of residents for a couple of years, and I'd love to link up and have a better sense. So if this is familiar and you got it somewhere else, I want to know where and talk to them. But a lot of people are telling me that they might hear a little bit about burnout, time management, refreshing yourself, go for a walk, and that kind of stuff. And then, have you found a way to build this into your practice? The other thing is, it's very important to explore our particular vulnerabilities. We're all different. And if you have had a traumatic experience, or if certain things resonate with you, it's really important to be aware, so that you can kind of have a red flag through your day. Oh, this is really going to come home with me. Let's see. Okay. So we're going to do a breakout. We're going to do 2 people here. We're going to talk about low impact debriefing first. So this is a really important thing as to address where our stories go. There's this idea that we can kind of contaminate each other with trauma. And you could call it tertiary trauma if you want. But it's really, I might come into work to do some research at my office, and then someone comes in and is like, oh, I saw this person and they were this and this happened. And, I'm getting the vicarious trauma, and I'm not even on a clinical service, right? So we need to be mindful. It's really important to kind of wash our hands before engaging with trauma. I'm starting to think of this as an infectious disease, really. And I think there's almost like a hospital epi level, like vicarious trauma thread here. And then what if you're partnered to someone or a close friend with someone who's not in the medical field, right? Are they prepared? Do they have the armor that we've built over the years to hear your stories without it affecting them? So there's this idea of low impact debriefing, which is basically a way to process what you're seeing every day. And I can't emphasize this enough. This is not just the post code that didn't go well. This is, I admitted a person with cellulitis, they had a really hard life. And how can we share this, get it off our chest, but not sort of slime other people with it? So one thing is to cultivate self-awareness. Slow down, notice, when you're having conversations about these things, just have a little light bulb go off, a little bell that says, okay, I need to, how much am I pouring out? Fair warning is huge. I've started doing this with my wife in the last several months, and it's been huge to be like, there is some trauma here. Are you in an okay place to hear it? How is your day going? Consent comes with that. Is the person willing to hear your story that comes with some trauma? And then limited disclosure. You don't have to tell the juiciest parts, the parts that make for a good podcast, good TV, that kind of stuff. We desperately want to, I at least desperately want to tell that crazy story about that crazy thing that happened in the ED. But what's the part that made you suffer? What's the part that's coming home with you emotionally? And does that have to have the full gory details and adjectives of this, that you kind of want to tell sensationally? Because you actually often don't need to share everything. You can say, this thing happened and it made me sad, and not go into all the details. So these are key strategies to being able to share without sort of passing on the trauma. Let's take a breakout. We're going to do 3 minutes, and then flip. I'd like you guys to think of some not particularly high impact, but something that was hard, something that you saw and experienced that would fit as secondary trauma, vicarious trauma. And I'd like each of you, or two-person dyads, and then share for 3 minutes. Then we'll get a bell, I think, if you can do that. Or a message will go out, and then in 3 minutes, flip roles and share again. I'd like you to try to be aware, try this fair warning and consent to just go through the process. Okay, let's go ahead.
For some reason, can't hear you, John, even though it looks like you're unmuted.
Sorry, my microphone was off.
Oh, no worries. Yeah.
Andrea, thank you for doing this. I don't think we've met in person. I've seen your name on some charts. I'm
Same.
one, I'm one of the associate program directors in the program, so thanks for doing it.
Sure. Thank you for having me. I've been sort of reassessing as I'm coming out of early into mid-career what I care about, and this is the center of it. And so I'm just trying to figure out ways to
Yeah,
operationalize it.
I don't like it when people say mid-career because that means,
Fair enough. Uh, how about as I'm losing my early investigator status?
yeah, maybe that'll work.
Yeah, no, it's certainly not mid-career temporally. Hopefully.
Yeah, I don't think this is formally taught in other settings, Andrew. I mean, at least for me, this is the first time I'm hearing many of these terms. I've heard from friends, about compassion fatigue, but not in a way that's been structured. And so I really appreciate this.
Yeah, no, I think I've probably asked but somewhere between 50 and 100 residents, and I'd say zero have heard uh, both of those ideas, compassion fatigue and vicarious trauma. Um, and
I'm
I've reached out.
imagining that it will come up, if not directly by you, but in the questions. But I mean, I think that the inevitable conversation here is about what the overlay of what's been going on in the pandemic, right?
Yeah,
I
yeah,
mean, everything that you say to the nth degree, because there's fewer rest cycles and there's more demands and all that sort of stuff.
yeah, yeah, and just I think between pandemic, the increased awareness that I feel like our world between Ukraine and Black Lives Matter, these are things that have been happening forever that are it's no longer cool not to be aware of. And I feel like that suffering awareness has increased, certainly not as much as it could, but I think it is increased, and that comes with these problems.
The other overlay, just so you're aware, and you probably have caught some of this, the residents have been impacted additionally by, and there's been a lot of conversations within the program and with the residents in the program about the impact of, we call it our risk system, right? Like our coverage system,
Yeah,
our risk pool, just as it is for the hospice, just as it is for primary care providers, the risk pool for the residents has been completely depleted.
yeah,
And so just so you're aware of that, that's very much on mind, I think, of a lot of the residents as well.
yeah, yeah. No, I talk whenever someone's covering risk, I'm hearing like risk used to mean like recharge, maybe work, and now it's just another work shift.
Yeah.
Thank you. Um, yeah, and this is I'm sort of intending this. I'm assuming that there are other spaces that are talking about sort of burnout and self care and these things. So that's I mean the end of all of the books about this stuff transitions, as you might guess, back into like eat your vegetables and go for a walk and meditate. But I'm trying to like make for the 45 minutes I have like make just the highlights that you people may not have heard of.
Well, we could all eat more vegetables and
Absolutely. No, and I don't mean to trivialize it because
yeah,
it actually is really real. All of those things are extremely important.
yeah.
But I remember as a resident being told like prioritize this and that, and when I was at Baylor violating every duty hour, every shift, and it was just felt so disingenuous to like go for walks, make sure you take some, and it was just like let's take off again. Hopefully that was a good opportunity to practice this. I can't encourage enough that you practice this with anyone who you're close to and each other. We've started doing it a bit in the hospitalist group, mostly me pushing it whenever I'm around. But I've enjoyed it, and a lot of people have had positive things to say about it. We're going to transition to caring for our patients. And I'm going to move a little quicker because I have 10 minutes, and this is a little bit more telling than processing here. We can help people with PTSD. this is sort of the highest level review of the literature, and basically kind of comes out saying that there are a variety of things that work, and it's counseling. There's desensitization. There's prazosin. There's a variety of things that are effective. This is not that talk, but we are able to help with this. I was looking for trauma. I was curious, is there something, I was thinking akin to the delirium protocols that we can call in that sort of blow in a bunch of kind of nurse language and help us better care for people once that's been identified. So I checked in the orders, and PTSD said, "Oh, did you mean trauma?" And I was like, "Okay, sure." And then it said, "Here you go." All orthopedic, right? 100%. So there's really nothing that's built in. But what does trauma-informed care look like? What does a good job of this look like? Now, there's this Trauma and Justice Strategic Initiative, very cool document, and it blends some of the equity issues into this a bit. The data is so poor that I'm not able to go there with this talk, but it certainly, as you can imagine, trauma has far-reaching, the interplay between people's kind of identity experience and trauma is rich and super intense. So this comes from that document. The 6 principles of a trauma-informed approach. So safety, and that really means establishing safety, explaining it explicitly to the patient, not just taking it for granted as we often do. Trustworthiness and transparency, again, establishing it. How do we actually let them know how we work? Remembering the lineage or the pall cast on our field by things like Tuskegee, what can we do to build trustworthiness and transparency for the patient's experience? Peer support, this gets to, we have certain elements of this, and then some of the things that we were talking about are in there. Collaboration, mutuality, that means between patient populations and we as care providers. Empowerment, voice, and choice. So we're starting to have some of these things built into Harborview that I'm so delighted to see building agency for representatives of our populations. And then cultural, historical, and gender issues. So this is complex. This is all of the things that make, that sort of highlight for me the exciting challenges of individuality of experience caring for Harborview patients, but it's at all of our sites for sure. I want you to pause for a moment and just think, what are some assets that we have? So clearly no order set. What are some assets we have for trauma-informed care of the acute care patient, someone who's hospitalized? Run through your list. What would you put on your problem list or mention on rounds? We'll just give a brief period for you to think. Okay. And you can throw chats your way. Here's what I came up with. The hospitalist and PCP are kind of at the center during the acute care episode. A good PCP who's reaching out can make a world of difference for that transition to inpatient and out. Rehab psych, that's the one that gets thrown around on words a lot. Oh, good call. They have a very specific population they're trying to help and don't want to help every person with trauma. They've become more and more focused on that as we've made them very busy. Social work, you know what their ideals are and what their realistic capabilities are. So I won't say more. Psych consults, when there's a sort of axis 1 problem acutely interfering with care, yeah. Otherwise, kind of tough to reach out to them. Spiritual care, palliative care. Again, these have very focused reasons. You don't just call them for my patient has had trauma. Engaging the nursing team. Volunteers. Often that's a bit of a terse interaction, but can be leaned into. And then friends, family, religious community. This can be huge. I've reached out and gone to mosques and sat down with an imam who started showing up like 3 times a week and made a world of difference. This is attending stuff when I have, week on, week off. But you can reach out and really pull people in. Again, hard during COVID, but possible. Text me if you have other thoughts, but these are the kind of realistic things. And you can see they're all not perfect. There's no sort of trauma care team. So I'd love any thoughts that you guys have in terms of other assets that we could build or develop, other kind of systematic approaches that sort of the SAMHSA talks about but doesn't quite lay out. Any thoughts you have now or going forward, just email me because I'd love to go sort of a step further in terms of making our joint campuses better at trauma-informed care on a systematic level. Again, most of those, as you saw above, are very individualized. So it's a very different thing from, depending on where someone's coming from. I do want to highlight we have a trauma abuse and trauma center. So this is a funny hodgepodge, but it's at the Pat Steele building. And it's medical and forensic services. This is where the sane nurses for sexual abuse and trauma live. And they have a clinic that they kind of are, it's a walk-in clinic. They also will run over to the ED for our exams. But this is much more of a medical documentation forensic space and not necessarily trauma care. They have therapy services, and so they'll do psychosocial assessment and treatment. And so that's the part I want to point you towards, that a referral via your CCN could be really helpful for the right person. They also have foster services, which is interesting. So it's kind of a little parentheses around some things that make sense together, but are also very different. I want to highlight, so children and teens are very much welcome. And then they have a preference for people with an actual sort of clear traumatic event within the past 2 years. And then on a case by case, which you can read as how busy they are, they will help with people who've experienced other trauma further back in their experience. But this is one action item you can now add if you haven't heard of this before. A referral to this center is not a terrible idea for someone who experienced, one of the myriad forms of trauma that our populations are experiencing, and whether it was 2 years or earlier. Now, the evidence-based treatment that they provide, they have CPT, cognitive processing, prolonged exposure. These are all the sort of trauma psychological approaches that we have, and then common elements treatment approach. I'm going to assume that someone here hasn't heard of this, because it was new to me, but it's basically how do you provide the best of expensive, fancy therapy that people with insurance and money can have in a cost-effective way. And you can picture basically there's modules. So you're thinking in different way, part one, but then this other pathway going across, substance use reduction. And so it basically has these small group modules that you go to in a sort of pseudo-linear way but the choice of modules is tailored to the diagnosis. So it's modular, flexible, and transdiagnostic. It's a great way to provide cost-effective therapy to people who may not have full-on weekly therapy available from a financial and time standpoint. So we have this CETA at that clinic. Last thing I want to mention, some further reading. If these things resonate with you at all, I think the first place to start is the Trauma Stewardship book. I want to highlight her perspective of stewardship, the idea that the steward of a kingdom or stewardship of a forest or antibiotic stewardship, you don't own the case, the kingdom, the forest. You are helping take care of it, but it's not yours. And that's that space between kind of being able to be empathic, but not turn into like a profound fatigue and world-changing perspective. So that's kind of the root of all this. I think the compassion fatigue workbook is well worth the purchase. If money is a problem, hit me up. I'm attending. I will, like, if it's something you're passionate about and money is in between you and this book, I will buy it for you. It's so valuable to just kind of work through this stuff and start building it into your way of being and your process. The Body Keeps Score is a very kind of old school, I'm not sure how old it is, but it's a lovely perspective of how the body and mind interact in the trauma perspective. And then America's Racial Karma is amazing by Larry Ward. He's a PhD and a Buddhist teacher. And it has just an incredible way of looking at the trauma, the intergenerational trauma built into the lived experience of specifically Black Americans, but it really like reaches out to kind of everyone from a variety of different backgrounds, how intergenerational trauma works. It's very much in a Buddhist framework, but it's really clearly laid out and just a fascinating read that really kind of helped me understand and has some to-dos, has actual proposals. It's not just like, here's a way of thinking about something. So it's filled with, it's a hard read, but there's some hope at the end. And then Flowers in the Dark is from a more Buddhist perspective. These are just some phenomenal books that I can't recommend enough. Okay, thank you guys for your attention. I want to make myself available if you have thoughts on this, whether it's questions about how this applies to you or further questions about kind of building this into your practice. I am available, just email me. And if you have questions or ideas about improving our trauma-informed care, same, hit me up. Thank you so much for inviting me. And I will definitely read, if you guys, there's some mechanism I imagine for feedback, but this is my first time doing this with residents. So if you know, a shift in emphasis or whatever, I'm very open to hearing about how to shift this for future opportunities to share. Thank you.